Thank you, Victor. Yeah. I hope everyone can hear me okay.
Stop now.
So welcome everyone to this. Great, thanks. Welcome everyone to this session. It's the fourth session in the series of sessions that we've had over the last 2 days. We're quite excited about this particular session. Thank you everyone for joining. I see that we have quite a great turnout today, so that's great. A huge thank you to our presenters for taking the time to join us. But before I go ahead, I'll ask Chris Lewis to come in and introduce himself. Chris is the discussant for our session today. Chris, over to you.
Thank you very much, Stella. And thank you all for joining. Thank you particularly to the external people from outside FCDO that are going to be presenting and discussing. So really looking forward to hearing what you have to say. It was great to see that video and to see some of the things that Chris Porter was highlighting then in that interview, and just to say thank you to the East Africa Research Hub. We are talking about COVID-19 and global health security, a subject which, whilst many of us have been trying to get away from this for the past year, it's been the center of our professional, for many of us, it's been the center of our professional and our personal lives. And actually, so my current role, I'm the Deputy Chief Scientific Advisor, the Head of Health Profession and leading the Science Cell. And it's been very good to work with the East Africa Research Hub on a number of initiatives over the past year, including some of the work really looking at what we should be doing and actually what the evidence is telling us in East Africa on physical distancing. And actually it's been very interesting to look at some of the epidemiological surveys. I think we'll hear some more about that, looking below the surface of what is actually happening in terms of cases and deaths. So really looking forward to today's session. Thank you, Stella, for bringing us all together, and looking forward to a really good discussion. I think one of the challenges we've seen is this is much as we look at East Africa, much of the evidence is quite grey, and it's really good to hear about the evidence, but actually really important to debate it, and looking forward to some of that debate this afternoon as we discuss. So thank you all for joining. Look forward to it.
Thank you, Chris, for those comments, and it's really good to hear you, just speak to how working with the East Africa Research Hub has been helpful to you in your role. So before we get started with the presentations, just reminding you that if you're not speaking, to please remain on mute, and also just turn off your videos so that we can, or your cameras rather, so that we can conserve our bandwidth. We are recording the session just so that we can share it with those who are unable to join us today. And we'll take questions at the very end. So do post the questions on the chat. And if they're directed to anyone specific, let us know as well. Thank you to everyone. And let's kick off with the presentations. I do hope Ambrose is with us.
Hi, Stella. Yes, I am.
Great to hear you. Ambrose, over to you.
Excellent. Thank you. Thank you.
We'll get the slides up shortly.
No problem. I could just start introducing myself as they come up. Really, thank you, Stella, and the rest of the EARF team for convening this meeting and giving us an opportunity to share. I'm doing this on behalf of a very large team that sends their regards. So my name is Ambrose Agueyu. I'm a pediatrician, but I also head the Department of Epidemiology and Demography at the KEMRI Wellcome Trust Research Program. Our program is based in Nairobi and Kilifi, with collaborating hubs in sites across the country and the region. So I can see your screen and the slides, Stella. So perhaps if we could go to the next slide, please. Thanks. So as was the case for most institutions, with the beginning of a pandemic, almost all regular work ground to a halt. So working closely with the Ministry of Health, we repurposed our work towards questions that could address priority needs for the government in response to the pandemic. We then worked with colleagues, Stella and other colleagues in the East Africa Research Fund to refine the proposed work and then defined linked work streams around Sero-Epi that leveraged expertise and experience within the KEMRI Wellcome Trust program. So we realized that not all these work streams could kick off at the same time, and there was an exercise of prioritization. So, for example, residual samples from blood donors were a convenient source of specimens, but we also appreciated that they have an inherent bias in terms of this population being used as a proxy for the general public. So the results of this were first to come out, but we did acknowledge that ideally what we would want would be samples which are less biased. These findings have been published and peer-reviewed and published, and I think be happy to share that literature with you if you're interested. ANC clients, this is a population which was expected to continue to be accessible during the pandemic, and samples from women attending ANC were regarded to be slightly more representative than blood donors when you restrict it to the general population of women within the childbearing age band. We now have early findings from this population, as you'll see in analyses that I'll be presenting. And then the ideal design really, of course, is a population-based age stratified survey, but we're aware of the challenges of setting this up, and we knew that data from this would come further down the line. So we managed to start fieldwork for this work stream late last year, and we anticipate some preliminary results fairly soon. Other populations that were identified as priority groups to monitor over time because of their role in the economy and pandemic response, as well as risk of exposure, included healthcare workers and non-healthcare frontline workers like truck drivers. These populations would also be of interest in terms of prioritizing vaccines as they're becoming available. And then PCR positives are the other target population from whom we've been collecting samples to study the immune response across the clinical spectrum of disease, and especially in Kenya where we have over 90% of our reported. I'm sorry, there's quite a bit of background. Okay, much better now. Thanks. So the data from these PCR positive individuals will play a critical role in helping interpret the findings from other work streams amidst the ongoing debates around variability in potency and the durability of immunity in various populations, especially as we think around long-term protection, both from natural exposure and vaccines. So next slide, please. So we know that seroepidemiological studies are only really as good as the assay used. colleagues in our bioscience department adapted and validated the Kramer ELISA for SARS-CoV-2 IgG using samples which we have archived in our biobank. So 910 samples from the pre-pandemic period and 174 sera from PCR positive cases during the pandemic, collected during the pandemic. And in addition to that, we had some additional well-characterized sera from a panel from the National Institute for Biological Standards and Control in the UK. So the sensitivity and specificity of our assay, based on the pre-specified threshold for seropositivity, was 92% and 88%, just under 88%. Sorry, and 99% specificity. So fairly high specificity and reasonable sensitivity as well, validated against local samples. Next slide, please. So this slide summarizes a number of our findings so far. The figure on the left shows the cumulative confirmed cases per million population in Kenya as reported by the ministry's case-based surveillance. Overlaid on the graph are point estimates of seroprevalence from the various work streams that I've referred to. And most of the data, as you can see, represent the tail end of the first wave through to the second wave, which ended towards the end of last year. On the right are region-specific modeled trends illustrating the heterogeneity we see across the country, with rising prevalence most apparent in Nairobi, Mombasa, and coastal Kenya. Just useful to note our populations such as ANC clients in Nairobi, in whom seroprevalence was estimated at 50%, and healthcare workers from the same setting was at 43.8%. Truck drivers in Kilifi and in the western part of the country in Busia, seroprevalence estimates in the 30s and 40s. Next slide, please. So we conclude the following from these findings, which we have so far, that seroprevalence has risen through the first wave nationally based on our blood donor data. We have estimates of around 9% at the beginning of September. The rate of spread has varied substantially across geographical regions, with faster spread in Nairobi and the coast. And the seroprevalence appears to vary quite markedly across populations as well, with remarkably high estimates seen among ANC clients in Nairobi. There's wide discrepancy which we're seeing between the findings from the Ministry of Health's case-based surveillance data and even the hospital-based surveillance, which we're seeing indicate that there's an immediate need for reliable data on mortality, including community-based studies to understand whether Kenya has experienced a hidden toll of deaths. And then we've managed to share these findings with the ministry and continue to generate new data that will continue to update our understanding of the pandemic. Next slide, please. So members of our team sit on various technical working groups in the Ministry of Health. We have shared with colleagues in the Ministry of Health, Office of the President, and indeed Stella and Samora, who are from FCDO, join other colleagues in monthly meetings where we discuss these findings and debate some of the policy-related implications with our colleagues in the ministry. And We have policy briefs that are also publicly available on our website. We have manuscripts that have been deposited as preprints on medRxiv for most of the findings I've shared, and some are under peer review. Next slide, please. So we're currently discussing how we might pivot our work towards addressing emerging questions to monitor the ongoing vaccine rollout. This slide lists just some of the thematic areas that are under consideration, and building on the successes of what we've learned over the past year working with EARF and other colleagues. We hope to apply similar approaches to monitoring the pandemic in the context of vaccines. I'd like to end with just a quick word of thanks to the FCDO and EARF team and the Bill and Melinda Gates Foundation and Wellcome, who co-fund this body of work, for placing trust in us to execute and deliver on the project. I remember very early in the pandemic, there was a lot of skepticism around serological studies, including our proposed work. So thank you for believing in us, and we hope we can continue to partner together on other emerging priorities moving forward. And thank you all for listening. Back to you. Thank you.
Thank you, Ambrose, for that presentation. As always, it's always so good to hear about the progress that this study is making. So thank you for joining us and for your presentation. So we'll now welcome Professor Diana Mitlin. Diana, please come in and just introduce yourself, and then just proceed with the presentation. Thank you.
So thank you, Stella. Can you hear me?
Yes, we can.
Okay. Perfect. It's always a little bit unknown in this world. Okay, so thank you, Stella. Thank you also, Ambrose. I really enjoyed your presentation. So my name is Diana Mitlin. I'm Professor of Global Urbanism at the Global Development Institute at the University of Manchester. And I'm also a research associate at the International Institute for Environment and Development. So this is a very different research study. This is some work that we were asked to do about probably the third week of March. If I could have the next slide, please. Okay, so we were asked to help FCDO with a rapid response. I think initially we were given 5-day turnaround. Of course, we stretched it a little bit, in part because of the wealth of comments that we got from really a superstar cast of reviewers, both inside Kenya and beyond. So we were asked through the East Africa Research Fund to provide policy advice to FCDO that they could share with the government of Kenya on how best to respond to COVID-19 in urban informal settlements. We were just tasked to produce that report, a 4-page high-level policy advice, looking particularly at the policies they should have to address the health and economic emergency, and also to think more generally about what they needed to prepare for. It seems hard to think it was only a year ago, but clearly it was a context in which there was considerable uncertainty, no little scale of fear, but already really a lot of action going on and a lot of problems evident in low-income informal settlements. Yeah. If I could have the next slide. So I wanted to touch on some of the findings and recommendations that we did. We, I think, produced really both short and medium term responses. So we really stressed, drawing particularly on the work of the Ebola crisis in West Africa, but also building on a history of engagement between informal settlement residents and county as well as national governments. We really stressed on the need for a response built on an inclusive partnership, the need for a joined up and coordinated response, but one that really worked very closely with the people experiencing the problems and the organizations of those residents, in addition to local government being really critical, community health workers and volunteers, as well as support from the relevant national ministries. So At one level, there needed to be substantive partnerships. At the other level, there needed to be very strong communication between all parties. Information about the problems and the experiences needed to flow upwards, and appropriate messaging needed to flow downwards. I think we recognize the need really to co-produce a response, because if that response was not co-produced, there was a very high risk that government interventions could exacerbate the problems. We had a summary component to our policy advice about things that should not be done. The need really to assume a little bit, as has already been said, that there's diversity in what is going on, and the need to really work closely at both this economic process, for example, with local food outlets, but also to ensure that there was no alarmist messaging and that those with COVID-19 were not further stigmatized or did not have more problems because of stigmatization. Next slide, please. So what were the outcomes and impact? So the brief was circulated, as you would expect. There was, I think, or I understand from FCDO colleagues, there was an appreciation of the value of the advice from the government of Kenya, who engaged further with FCDO around these issues. I think more generally, there have been some very positive trajectories in Kenya. I honestly don't know if our brief had any influence on these, but I do think they're worth highlighting. I think there's been a respect for community data. There's been an awareness among county and governments about the importance of really learning from communities about what is going on in terms of the incidents, but also how they can help. For example, how communities can help to identify isolation centres for those who experience COVID-19. There's a recognition of the importance of inclusivity at the task force level, and really a formalisation of these much more ongoing everyday engagements between state agencies and community groups. And there's been economic support for those living and working informally, and those I work with in informal settlements are deeply appreciative of the response of the government to understanding the acute crisis that they faced. Next slide, please. So what next? I would say it's hard to imagine the headspace we were in a year ago, and I don't think we anticipated how long the COVID-19 emergency would go on. I think we recognise, both in this work and more broadly, about the need to carry on learning about this. And I think there are a few priorities, research priorities, that are things that we're already working on, in addition to having a much broader constituency of research around them. So the first question is, how can the pandemic response and measures related to that be co-produced between relevant authorities and local communities? Recognising the importance of local ownership. How can affordable basic services be provided to informal settlements? I think the gaze of the world is now much more aware of the significance of these overcrowded, underserviced neighbourhoods in the global north and global south. And I think policy makers who did not understand the significance of urban poverty for prosperity and well-being now have at least some appreciation. And we, as researchers and as a research community, we have to work on advancing that issue. I think related to that, there's a real understanding about the fact that we need to better support urban livelihoods to be more robust and less insecure, because a lot of the challenges around economic interventions have been the fact that they're starting from such a low base, that urban poverty is so acute. And I think most recently, something we're crafting at the moment is an understanding about how equitable is the vaccine program that's rolling out in a number of countries in the global south. And how can we assure that equity is achieved? How can those who most need it get access to vaccines? Which first requires us to understand what is happening with that rollout. So in terms of what next, I would say those are the key research priorities from someone who's really worked very closely with informal settlement residents over a couple of decades now, and tends to look at the economic and health challenges through the experiences of those very vulnerable, disadvantaged groups. Thank you.
Thank you, Anna, and also thank you for keeping to time. Dan, I do agree that this is it is an important contribution, like to our discussions today. With quite a large and growing population of urban dwellers that live in slum settings, it's quite important for us to be paying attention to this. So we're moving right along and inviting Joseph Ding, speaking to community approaches to epidemic management in South Sudan. Joseph, over to you.
Thank you, Estella, and those presenters for their excellent presentation. I am Joseph Ding, a Rival Institute researcher and a member of the wider research team that conducted a study on the work I'm presenting now. My presentation is a study on community approach to epidemic management in South Sudan, a study conducted in 6 locations between August and November 2020. So move to the next slide, please. Yeah, thank you. Across South Sudan, long before the global COVID-19 pandemic emerged, communities across the country have created a system and structures to control the spread of epidemic and other infectious diseases. South Sudanese people have extensive knowledge of infectious diseases and experience of organizing response to epidemic during war and also other crises in the past. Most people have experience of multiple epidemics within their household or in the neighborhood. Many informal healthcare providers have been involved directly in organizing medical responses in the past to this outbreak. So in several areas across the country where infectious disease broke out, people have been involved in contact tracing and also management of the sick people since 1970s. This study therefore responded to 3 connected questions raised in the early 2020 when COVID-19 broke out, whether are individual prevention methods and lockdown model appropriate or possible, given the fragile state of clinical health care, the reliance of most people on insecure daily income and other labor incentive livelihoods and continuing local conflict. Or can misinformation, rumor, and messaging fatigue among a population struggling with many other immediate priorities and life-threatening risks be effectively overcome? What local strategies for stopping the spread of highly infectious diseases could be adapted or are being adapted by residents to respond to the threat of COVID-19? Our research aims to highlight existing community strategies and systems for infectious diseases management that could be integrated into effective and trusted epidemic responses now and in the future in case. Our research findings in the full report detailed community infectious diseases management strategies that have been developed by South Sudanese people to respond to past epidemics and which are being adopted currently in a fight against the risks of COVID-19. The research was conducted between August and November 2020 in the broad geographical areas of Central Equatorial State, in Western Baragazal State, in Upper Nile State, in Northern Baragazal State, and Rukona. The locations where the research were undertaken were identified by the South Sudan Ministry of Health COVID-19 coordinated response as areas of higher vulnerability to epidemic outbreak in the past and now. In each area, the South Sudanese research team met with a wide range of respondents as possible across urban centers and rural villages and also settlement and cattle camps. Our respondents, which we sampled, include young women working in homes and also in market, migrant workers, all women with herbal medical expertise, traditional birth attendant, male and female military personnel, village pharmacists, cattle care leaders, local community clinical workers, teachers, farmers. We also interview pastors, disabled people, land elders, and traditional authorities. Most of these interviewees have personal knowledge and experience of multiple infectious diseases in their households and also in their own communities, dating back to 1940s. So in total, we interviewed 114 interviewees, and 49 of these were women and 65 men. Can we move to the next slide? Okay, thank you. So in our studies, we find that communities also have tested method of infectious diseases management, isolation, and also hygiene practices, the interruption of surface viral transmission, the triad, and also surveillance, adaptable during emergencies. Across the research, across the 6 research sites where we conducted a study, people discussed tactics for stopping surface transmission of viruses and bacteria and fighting airborne transmission through social distancing. Many of these strategies involve social distancing, careful hygiene practices, and also reducing the risks of surface transmission. Local, informal, and non-clinical medical workers in the rural areas are aware of the risks of symptomatic transfer. This is a strong basis on which to build on. We therefore recommend to build community epidemiological knowledge. We recommend that projects learn about and build on the measures people are already taking in their areas of operation to minimize the risks of transmission and to organize homes and workplace to maximize social distancing and to safeguarding people in at-risk category. These include common herbal remedies for reducing fever and for treating pulmonary and respiratory tract infections, such as whooping cough. In 2020, people across South Sudan are trying to work out what methods they can adapt to take the threat of COVID-19 based on their compatible. Many people who were interviewed suggest that COVID-19 should be explained in the terms as tuberculosis, which is taken very seriously across the communities, with widespread knowledge about its airborne and contact transmission method. Connect with community planning practice and response. Collaborate with wider non-clinical health care, especially people intervening against COVID, and caregivers, who are often first responders, including women, midwife, herbal experts, and local clinical drug sellers in the rural areas. We recommend training and support to these informal first responders. Herbal medicine experts are generally very open to clinical training and advices. Supporting locally respected caregivers as part of the epidemic response will likely mean that the epidemic and central epidemic planning management plan will more likely be taken seriously by the local community who continue to ignore COVID. This collaboration will also help local public health team identify the best local tactics for interrupting transmission for COVID-19 as well as other infectious diseases which are prevalent in the rural areas. Third, support frontline caregivers outside the clinical system. In both South Sudan and maybe across Africa, communities are urgently demanding more practical information and training on COVID-19 and other infectious diseases that build on their existing level of epidemiological knowledge. People in more part of South Sudan note that they do not fully understand COVID-19 transmission. With a proper understanding of symptoms, disease progression, and transmission risk, people can better protect themselves, identify suspect cases, and care for sick patients more safely to protect themselves as well. Support communities with a broad epidemiological knowledge and logistical skill to prepare for COVID-19 and other epidemic outbreak. Build sustained and detailed public health information system to keep local non-clinical workers locally prepared to fight the infectious diseases management strategy. More detailed and sustained information drives in partnership with local first responders will also build trust and counter misinformation and messaging fatigue, which is very prevalent in the rural areas now. The next slide. Yeah. Thank you. Communities have received limited public health information. The focus is mainly on preventive measures and the risks of the virus and being subjected to a national lockdown. This fast-paced messaging during focusing on individual risk mitigation has not addressed the reasonable doubt among many South Sudanese people that think or believe that COVID-19 is only a risk for one of the people who are able to travel and thus become infected, and that national politicians and aid workers are asking poor citizens to suffer major economic stress for nothing. Our research suggests that brief one-way messaging campaign are insufficient to address the information and planning needs that communities emphasize are critical for their ability to plan transmission minimization strategies appropriate for their local geographies. And to combat fatigue, doubt, and misinformation within a sustained crisis. Our report encouraged engagement in a sustained dialogue at sub-county and PAM level that share information about the progress of the epidemic nationally and globally, including new information on interrupting transmission and risks. We suggest that being open and honest about the inequality and systemic problem exposed by the pandemic will likely build trust in project activities rather than undermine them. So we recommend that build localized healthcare management and planning system. As part of this, the research emphasized the need to localize epidemic response planning. Epidemic messaging campaigns in South Sudan generally rely heavily on one-way public health communication, focus on the immediate disease risks at a symptom and the individual case-by-case action needed. This central planning overlooks critical local knowledge and community leadership that will actually make responses happen and make them effective. Public health strategy should aim to build on measures people already take to try to protect themselves and their communities from multiple infectious diseases of the past. Because of this is both realistic and create trust and understanding between the NGOs intervening and the local communities. Local consultation that include women, sheep, pharmacies, and also clinic workers, herbal experts, and elderly people, especially elderly women, would strengthen project design and better support the uptake of campaign information and action. This should reflect past community level planning and respond to other epidemics. We also recommend that the relation should be build a holistic collaborative health care system in South Sudan. Collaborative planning should aim to build community of leadership with civil servants and state healthcare staff, traditional authorities, NGO-funded clinic workers, herbal experts, and clinical drug sellers, laying the foundation for a sustained response to COVID-19, but also to other epidemic and endemic diseases. Localize the response planning will also be able to include the self-protection strategies of disabled community members and mean that program staff can listen to the need and suggestion of families caring for people with severe mental and physical health issues. Finally, we recommend reflecting on the structure of international healthcare support in South Sudan. We note that funding framework tend to be reactive to health crisis and focus on individual endemic and epidemic diseases. The response to COVID-19 reflects this. But South Sudanese people deal with a multitude of medical issues and airborne diseases, of which COVID-19 is just one more, even if it is particularly dangerous. Many people are frustrated and annihilated by the specific COVID-19 emergency response because they feel that this demonstrates ignorance for the other problems they face that are more pressing or as dangerous, threat to life and health, and that they face, which are chronically underfunded or receive no attention at all. We support that. We support the move that has already started toward a holistic reconsideration of how to support South Sudan's healthcare sector holistically and collaboratively. Yeah, go to the next slide. Yeah, our outcome and the impact of our study. We have presented this study to South Sudan's key COVID-19 planning bodies in Juba. We have also stressed our support, our say to support UNICEF, South Sudan Red Cross, and the South Sudan Ministry of Health. We have shared the report and the briefing widely to government institutions and to many other health NGOs operating in South Sudan. We are also undertaking community dissemination through radio programming, and we have translated the recommendation of the study into 6 main local languages, including Juba Arabic, as a basis of disseminating this report to the local communities who do not read or understand English. I have some of my research colleagues present that will be able to answer some of your questions in case of any. And thank you a lot for hosting us to present our finding to you. Back to you, Stella.
Thank you so much, Joseph. It's really very interesting to me to hear about local community knowledge and experiences informing the COVID-19 pandemic response, and also how in turn we could also improve these communities' management of COVID and potentially other epidemics that they may face. So it's really interesting to hear that. Thank you. So we'll move right along. Alex and Michael will be co-presenting on the COVID data challenge. So welcome to you, Alex, and Michael, over to you.
Thank you. Thank you, Stella, and thank you very much for having us here today. My name is Alex Losnanu, and I'm the innovation lead on COVIDaction. So I'll start by giving a brief overview of the program, and then I'll hand it over to Mike, who will share about our work on using data for vaccine distribution. So if we could move on the first slide, please. COVIDaction is an FCDO-funded program looking to build a technology and innovation pipeline to support the response to COVID. And it started as a partnership between FCDO's Frontier Tech Hub program that I think some of you on this call will know, the Global Disability Innovation Hub, and UCL's Institute of Healthcare Engineering. And we've started our work exactly this time last year. As a matter of fact, our 1-year anniversary was just yesterday. When we very quickly mobilized a number of open calls, touching on different aspects of global health that I believe will be interesting to this group. So through consultations with FCDO sector experts, with the Science, Tech and Innovation regional hubs, and entrepreneurs in Africa and South Asia, we focused our work on 4 emerging thematic areas that you'll see on this slide. We've started with the ventilators challenge in March last year, searching for frugal innovation in ventilator designs that could be adapted for rapid manufacturing. And this early work really has influenced our thinking in the oxygen package and our role in this area. So later last year, we partnered with UNICEF, and we've launched the Oxygen Collab, looking to build fit-for-purpose oxygen concentrators for low-resource settings. We then launched local production, local solutions, looking to address supply chains challenges, localizing production of PPE, localizing production of other unavailable goods due to the shortening of supply chains. And then resilient health systems, we've invested in 9 innovations in Africa and in Bangladesh that extend the reach and continuation of support of healthcare. And then data, the topic that we're going to address today, looked at technologies used to inform decision-making during the pandemic. And our COVIDaction method, all of this was really underpinned by what you see on the left, by our COVIDaction methodology that we call the SET process. So we scan the world for technology innovation that's promising. We then evaluate and sense make what we find with the help of experts in those areas. We then team up with relevant experts for technical assistance, and with FCDO country offices and sectors to make sure that the innovations are docked into programs. And then we share what we find and make available as a global good. If we go on the next slide. Today specifically, we're going to talk about the data work so the third area that you see on the slide, and specifically how our grantees that we've funded through the program have pivoted their work to respond to the vaccine prioritization challenges. So on data, our strategy since the beginning was to cut through the noise. There was a lot happening this time last year in terms of data tools. Cut through the noise, make awards, and showcase promising innovations. And we've made 12 investments to really exciting innovators and worked really closely with partners like GPSDD, the Global Partnership for Sustainable Development Data, to support the scale of these innovators and connect them with governments across Africa. And what we've seen very soon is that they've actually started to pivot their work again, using the same data sets, the same frameworks we've already invested in, but this time to respond to the vaccine prioritization challenges. So if you go on the next slide, we've started following them on their journey and try to explore the question around what's the role of data tools in terms of the fair and equitable distribution of vaccines. So I'll hand it over to Mike, who's going to tell you more about this particular aspect in our journey there.
Great, thanks, Alex. And if we can go to the next slide, that would be great. So we had a portfolio of 12 awardees in total that had developed tools that were really helping us make sense of the pandemic. A couple of these tools took existing data sets and brought them together in ways that were usable to make sense of COVID-19. So this is risk and vulnerability data, it's household and demographic data, it's health data, and then pulling these data together and so that we can make sense of what the risks and vulnerabilities are to specific populations. And what we found within the context of vaccines was a year ago, that was really interesting information. Today, it's increasingly even more important as we look at prioritizing in terms of vaccine rollout. So when now it was who is being impacted by COVID-19. Now it is, as vaccines roll out, how do we target these populations that are most at risk so that we can save lives, but B, also be able to understand transmission effects so we can potentially blunt transmission. And in the context of low and middle income countries, that crisis is very real, even more real than in many high income countries like the United States or the UK, where we see rollout taking place over the next several months or through to the end of the year. There is some research out of the Economist Intelligence Unit that looks at rollout through 2023. So the using data prioritization tools is really crucial for getting this right. So if we move on to the next slide. So we looked at essentially where data tools and vaccine allocation tools can play the biggest role. Essentially these data sets that we have access to. And the answer to that is, right there at the outset, right when we're starting to think about who is getting vaccines and how can we identify those populations and have that conversation around national priorities, because this is going to be a national issue. But the data sets are really crucial to having that conversation to understand where these populations are. And it's important to say that when you have the types of data that some of these tools provide you, which is the national level prioritization data, it allows for, and you see the life cycle of this, the vaccine supply chain off to your left here, it allows you to have access to that same data set throughout the rest of the life cycle. So as we begin to bring in additional data sets like information on misinformation or health facility locations, when you have a GIS-enabled data set, you can bring that together. And so we see this as kind of foundational data sets that we can help enable LMIC countries in using to continue to build upon the work that's already being done. Next slide, please. So getting really granular here, literally. We have some data sets here in Pakistan and Nigeria that bring together the data that we're talking about today, that provide WHO and UNDP in the case of Pakistan. In the case of Nigeria, we're working directly with the Ministry of Health alongside CHAI. And these data sets, if you look in the bottom right-hand corner, you see a map here that provides a index for risk and vulnerability to COVID-19, and then prioritizes against comorbidities and potentially mortality as it's linked to vaccine rollout. So we understand where, in the case of Pakistan, I believe it's those over the age of 50 with existing comorbidities reside, so that we can help prioritize in terms of vaccine outreach. And then in the case of Nigeria, what you're seeing is identifying these same types of populations across states, and then having states be able to take on that conversation and move it forward. Next slide, please. Great. And what this allows us to do in having some of these conversations with our grantees that have been at this for a year now is get at something, a lot of these items that Alex had talked about earlier, which is combating some of the noise in terms of the rollout from a lot of the tech tools and data tools that are there. We've been investing in these grantees and having these conversations, and these tools have been picked up by, say, other FCDO investments. Like Grid3 and others on the data hubs across Africa and other LMIC countries. We want to continue to invest in these tools, so there's continuity in the data tools that countries are coming to. We saw in the Ebola crisis that there was just a proliferation of tools, which means that there was a lot of noise. There was a lack of sustainability because these same tools were not being invested in, and then what that also led to was silos that were created. So despite the fact that a lot of investments were made, it was hard to bring data together and make it interoperable. Next slide, please. So the idea here is that we are investing in these same data tools. Right now, it's 6 or 7 countries across LMICs. Next slide, please. Thanks. And we're bringing on these relationships online within countries, while at the same time having the conversation about some of the larger issues that are going to be dealt with around GIS and micro planning down the line, which is essentially these vaccine campaigns that are going to be rolling out. So our investments in vaccine prioritization are really foundational. We're getting to the point of being able to now say to the GIS working group on micro planning within UNICEF WHO, these are some of the data tools that are coming online in specific countries that we think you should be aware of. So you can take these data sets and build them into the existing workflows and technical assistance and support that is going to be happening as COVAX ramps up its own technical assistance. Next slide. Great. And Alex, over to you.
Thank you, Mike. So having said all of this, we were thinking about, how might we take this work forward and what are potential pathways moving forward. And actually, what you see on this slide has iterated ever since a bit. So I'll walk you through these 4 different pathways. The first one is our current investments in innovators that Mike mentioned, Sergo, Frame, and working closely with GPSDD. Also include them producing really useful global guidance and research around what it actually takes to deploy these types of vaccine prioritization tools and what it takes to actually engage. So this research should be finalized by the end of by mid-April and presented at our launch event that Mike is going to share in the chat, and you can. We would love to have you, so do register. And on the launch event, we're planning to share the results, findings, and the global guidance as part of these initial investments. And then there's other avenues and other pathways that we think would be really relevant. So we're talking about matchmaking. So how might we work with FCDO country offices, programs, to assist in the adoption of data prioritization tools and making sure that we create this this matchmaking support. And then potentially even looking at matchmaking plus funds. So how might we then connect those needs and ensure alignment and introductions to UNICEF, to WHO, GIS working group in case there's any data gaps that need to be plugged in. And then lastly, the fourth pathway forward is plugging gaps through further open calls. We have quite a lot of expertise in this team around obviously running open calls, but this time these being very, very targeted to governments and to data partners that already have buy-in from government partners and surface and continue to plug in data gaps as well. So I think that's it, and I think our time is up. But I think Mike has shared or is going to share the link in the
It's there indeed, right off to the right-hand side. You can click and register for the event, and just to underscore kind of what's going to be presented at that event for this group in particular. I think it's of interest that we have research that's coming straight out of these initial investments we've made. These data prioritization tools, we're providing funding to understand how they can be used and taken up. And so you have Suryo and Frame, which are essentially chronicling their experience in the form of action research in Pakistan alongside UNDP WHO, and in Nigeria alongside the Ministry of Health and SHI, to be able to document that process. And that research will be at this event. Also GPSCD and a landscaping study on the data needs of LMICs across 8 African countries will also be presented at that event. So again, link off to this side. And thanks, Alex and Stella.
Great, thank you, Alex and Michael. Another very, very interesting presentation. Leaves me questioning the level to which these data will actually inform rollout of vaccines on the ground. We often see that it's one thing to have the information, but a totally different thing when we start to speak to, the resulting actions. So yeah, we can pick that up later. So at this point, we'd like to bring in via a video statement Sylvia Wamuhu. Sylvia is the Director of Health Systems at Population Services Kenya, or PSK, and she'll be speaking about a different program, Hand Washing Behavior Change Coalition Program, and specifically talking about behavioral change campaigns and broader policy lessons from the countries. This is Kenya's COVID-19 response. So can we get the video, please?
The HPCC program was set up by Unilever and FCDO to support low-income and middle-income countries to fight the spread of COVID-19. And the main focus of HPCC is to address the behavior change component and the communications component, whereby it is really targeted at increasing awareness of how populations can spread or curb the spread of COVID-19. So under this project, PS Kenya, in conjunction with PSI, has been addressing 2 main components. The first component is the communication component, and the second component is the building the capacity of the private health providers to just understand what COVID-19 is and align to what the government of Kenya is asking of them to do at the health facility level. So to start off with the communication components, PS Kenya has been utilizing its long expertise in developing national campaigns and working very, very closely with the government to develop the communication campaign that the government has been using and the country has been using. So we used mass media, we used social media, we used digital platforms, we used out-of-home communication, such as high traffic locations like the ferry, and also branded buses. The other component was on building the capacity of private health providers to understand what COVID-19 is and train them on the MOH guidelines. So that is what we are focusing on as PS Kenya, but we had many partners within the consortium that were focusing on the community level. The reach was very good. We reached about 30 million people. That was as at end of December, and the communication continues to run. So I'm sure the reach will even be much higher. Through social media, we ensured that we took advantage of the government accounts because we wanted to use a trusted, a channel. So we partnered with the government and we developed the content and we passed it on through the government account. And through social media, we reached over 8 million Kenyans. The HVCC project came in very handy because we got a lot of technical support from FCDO and Unilever in providing technical support over and above the funding, and also giving us some assets, some communication assets that were already ready. So what was also learned is that COVID is new and the issues keep changing, the messages keep changing. So it is very important for us to have some sort of adaptive implementation. Learn, know what the gaps are, what is new, and incorporate it in the communication.
Thank you for that, Victor. Victor, you can stop sharing your slide now. All right, thank you. Thanks for that. So, I mean, I think we can all agree that those were really, really very interesting presentations. So at this point, I would like to call back Chris. Chris, if you could just, just maybe start off with some reflections, and then we can take some questions. There are a couple of questions on the chat, but over to you, Chris. Thanks.
Thanks, Stella. Just in terms, I'm very happy to provide some reflections. Could I just check how, do you want me to just sort of provide some reflections for a couple of minutes?
Yes, yeah, sure. We're on until past, so we have 30 or so minutes.
Okay.
Yeah.
So what I'm going to thank you so much to all of the presenters. It was incredibly valuable to hear the different things. So thank you to Dr. Ambrose Aguayu. Thank you to Professor Diana Mitlin. Thank you to Mr. Joseph, Professor Joseph Majok, and to Alex Lozano and Mike Klein. So thank you to all of you, and also the video as well. What I would like to do is actually take some of the just to reflect on some of the key things and almost be looking forward, and actually how do we take some of these things as we look forward. In many of the presentations, I heard about the importance of balancing COVID-19 and non-COVID-19 issues. I think it was Joseph Majok that in one of his slides said the importance of the holistic response to all healthcare challenges that Southern Sudanese communities face. And I think that is critical. As we look at COVID-19 over the coming years, how do we balance COVID-19 and non-COVID issues in a sustainable way that both addresses COVID-19 but doesn't lead to a reallocation of energies to other key health issues and doesn't lead to an exacerbation of excess morbidity or mortality. I've heard the importance of us understanding the data, the COVID morbidity mortality, and again with my other point, and the non-COVID excess deaths as well, and the importance of really looking beyond the data, looking at the heterogeneity, looking at the inequalities in terms of the impact of COVID. And we've heard about the impact of the inequalities in the informal urban settings, but that has come through really very strongly, is how COVID-19 drives inequities, drives inequalities. And actually, it's really important for us to fully understand the heterogeneity and what inequalities are resulting, because actually the inequalities that are driven by COVID-19 will drive their own secondary impacts. And that's one area that I'm really very concerned about is the longer term scarring of the inequalities that COVID has led to. So as we look to the future, I've got a number of questions, and in a way this, I don't know if this could, as we look to the future, firstly, how do we maximize the overall impact in everything that we do, particularly in countries, we're talking about East Africa, particularly in countries in East Africa. How do government and ministries of health get the right balance of health financing and of effort to COVID-19 and non-COVID-19? I think there's a lot of health financing and health systems research questions that are critical in enabling maximizing the impact of efforts that are able to, over a sustainable period, over the coming years, that will be balancing COVID and non-COVID. How do we improve? We heard some great presentations about the serious surveillance that's happened in Kenya. How can we improve our surveillance of morbidity and mortality of new infectious diseases that arise in the future? How do we build this into existing systems? How do we strengthen our existing systems and enable them to work for new diseases? We've seen it. We've seen the challenges of understanding the actual morbidity and mortality, actual morbidity in Zika as well as COVID, and COVID just reinforced how important this is to really look at systems in Africa that will enable us to identify diseases and identify the true prevalence of diseases. Thirdly, questions around the vaccine presentation. What vaccine coverage, and this is a very hot topic, what vaccine coverage should be aiming for in East Africa? How do we get the balance of a sustainable vaccine coverage that maintains a coverage over time with a sort of short-term burst, and a more sort of short-term high ambition which may drop off at a later date? What are the pros and cons of both? How do we balance COVID-19 priorities, as I've said, with other priorities? How do we ensure that in focusing on vaccinations, we don't draw our attention, our resources, our finances, our people away from non-COVID, things like routine vaccinations, essential health services? How do we balance our vaccination? How do we approach vaccines that will actually minimize the risk of variants? Is this about having a high vaccine coverage, a high ambition, but actually potentially end up things being a bit more intermittent, or going for a more realistic ambition, which can actually be sustained over time? So which of these approaches will minimize the risk of variants? And actually, as been covered in the presentation, who should be targeted over the long term? And actually looking long term, how should we be using our COVID vaccination strategy over the long term? And lastly, actually linked to that, actually, as we look at COVID-19 in East Africa, how do we take a longer term approach? I think that looking through the research and looking through a number of recent papers, actually COVID-19 is likely to be with us over the coming years. And actually, how do we manage COVID, and how do we take a long-term sustainable approach to COVID-19 as another disease? And actually, what are the strategies for managing COVID-19 in the longer term in East Africa? For example, I haven't heard about the use of therapeutics and diagnostics. Actually, if we have an effective point of care diagnostic and an effective therapeutic, these could be used at a primary care level in order to manage COVID-19 as we do malaria. So what are the sustainable strategies? And whilst we're not there yet, unfortunately, I hope we will be, but what are the sustainable strategies for managing COVID-19 over the coming years in the long term in East Africa? But thank you so much to all the presenters. It was fascinating and really looking forward to this discussion. Over.
Thanks, Chris. That's quite a lot for us to think about, and it just goes to show how much we do need to be considering. So at this point, maybe I'll take turns and have us go in order of presentations, and I hope you've been noting down the I guess the broader questions from Chris. But we'll go in order, starting with Ambrose. Ambrose, as you're addressing one or two of Chris's questions, could you also just address the questions that we've received on the chat around if you've considered fast spreaders, including the business community or international travelers in your assessments, and your thoughts on the readiness to scale up sero safety surveillance in line with the rollout of the vaccines, and also how representative your samples were in rural areas, and if your sero surveillance can shed any light on trends or the trends or ways that we're observing through PCR testing. Ambrose, over to you. Sorry, that's quite a lot.
It is, but all very, very relevant questions. Maybe if I could just quickly start with Chris's earlier initial points around how we can build systems to enable them to work for new diseases. So I think that's very pertinent at this point. We have an opportunity, while COVID is still in the spotlight, to strengthen existing systems. So using a systems approach to ensure that we're not creating, there's a temptation to create a parallel system around COVID, given the prominence it has, but using or being intentional about trying to strengthen existing systems, which have received significant investment from government and partners, really, to ensure that they're adaptable to address emerging pandemics. This is a major issue right now, but it's unlikely to be the last, and being able to rapidly pivot systems to be able to identify and respond to pandemics makes sense. Right now, I think one of our big challenges is the quality of data we see within our routine health information system. So that could be something which the resources that have been made available during this pandemic, and also just the focus and attention, could be used to address as arguably as one of the quicker wins among many. On some of the questions in the chat, the state of readiness at the moment, I can see Leah has asked, how ready are we to scale up surveillance for both serology and safety? So many of you already know that the ministry has convened a national COVID-19 advisory task force, which has been responsible for rolling out the vaccine, including monitoring and evaluation. And any efforts which we are going to contribute towards, we would like them to be anchored within that wider framework that the ministry is steering. We have membership that is broad and includes colleagues from our research institute, but also many other institutions which are mandated with monitoring events following immunization. So some of the work which are presented, for example, could easily be adapted towards monitoring vaccine rollout. You saw that healthcare workers are one of our target populations. We are actively discussing how we might shift the inquiry towards monitoring vaccine of immune responses following vaccination, while also leveraging our platforms for surveillance of adverse events following immunization and additional questions around vaccine effectiveness in real-world settings. The samples were from catchments of health facilities serving or providing ANC services around Nairobi. So that was the Kenyatta National Hospital site, and then in Kilifi, the Kilifi County Hospital. So really it wasn't, if you're asking about representativeness, it wasn't, I wouldn't say it was representative at population level. For that, we'll have to wait for ongoing population-based household surveys, which will give us a more accurate estimate of the true population seroprevalence. Data from, I think there's a question around data from December to January. I think that's a question that's top on many of our minds, and we're as keen as you are to see where the cumulative exposure is right now, following not just the holidays, but also opening of schools. So if you stay tuned, we'll be looking forward to sharing those results. There are discussions around other priority populations, including monitoring seroprevalence and alongside the case-based surveillance for travelers. We are still in discussions around how best to set that up. So as new work streams begin to be set up and new data emerge, we'll be keen to share that both with policymakers, but more widely with interested audiences. I'm not sure if there are any other direct questions directly addressed to me, Stella. Happy to take on anything else.
None that I can see at this point. More might come, but let's perhaps give a chance to Diana. Diana, if you're, yes, Diana is still with us. Diana, if you can just think back to the questions or the reflections that Chris put forward. What are your thoughts? There is one specific question to you around, you know, what you think could be some practical recommendations or insights on how models for co-production in terms of a pandemic response can be encouraged between communities and the authorities. You know, any quick wins or practical entry points. Over to you.
Sorry, now thank you, Stella. So yeah, thank you very much for the discussion. So I have, I guess, 3 broad points I want to respond to. So the first is this question in terms of practical recommendations, insights and models on co-production for a pandemic response and practical entry points. I would say that, you know, co-production of services in particular has now a well-developed framework that emerged in the United States. So it has relevance in the global south, but it goes beyond that. And some of the early work was done on health in an acknowledgement that good health depends on people themselves being very active in addition to health service provision. So there is a recognition when co-producing responses that there are different types of co-production. So you can co-produce the design of a program, you can co-produce implementation, you can co-produce financing strategies, monitoring, evaluation, etc. In my experience, one of the most effective ways to begin a co-production initiative is, in this context, is co-producing monitoring. One of the groups I've worked with in Kenya is a group called the Muungano Alliance that immediately began community monitoring of incidents and government presence in informal settlements in terms of cleansing and in terms of health support. So monitoring, encouraging communities to monitor, provides information that health services that are focused on effectiveness appreciate. And I think you can see a number of initiatives that have developed. So moving on quite quickly, I think, Chris, one of the key things that you raised for me is this whole issue about inequalities and the need to think in an integrated way about COVID against other priorities. Clearly, COVID highlights things that are real priorities for communities, both in terms of better access to basic services, water and sanitation, and in addition to being included in cash transfer programs, social protection initiatives, etc. I think one of the advantages of a close engagement between communities and state agencies is that, of course, communities don't differentiate a COVID need from another need. So it provides a continual challenge to state agencies to go beyond their sectors. I think, just finally, one of the other questions also was highlighted me, and that was the question around barriers. And I think this sense about sectoral specialization is a barrier that communities face because they can't simply look at health. They have to look at economic needs in terms of pandemic responses. And I think initiatives that link local authority departments have been particularly helpful in ensuring that frontline services take into account this barrier. So not just the health services within a local authority, but thinking also about issues such as planning and such as utilities, which may be a municipal responsibility, but may involve other agencies. So thank you.
Thank you, Diana, for those very, very concise comments and reflections or feedback on that. Let's have some comments then from Joseph. Joseph, I'm just looking back to see there is one question here that's directed specifically to you about the biggest barriers to governments and formal health systems involving communities and informal health systems, and particularly in the pandemic response. What are your thoughts about that? But then reflecting back also to the questions that have been put forward by Chris that I have actually posted on the chat. Over to you, Joseph.
Okay, thank you. Thank you, Jordan, for the question. The barriers to the government and formal health system in South Sudan that created rooms for the involvement of the communities and informal health system in the country's wider health system is something more to do with economic and history of a conflict in South Sudan. So if we look at the years of the Second Civil War from 1983 to 2005, communities that were absent of Western medical doctors and in the most part of the then Southern Sudan, and communities relied on their own knowledge and skill to fight against infectious disease and also epidemics. So communities rely specifically on traditional authorities, the local health workers like the herbalists, the spiritual leaders, in treating and also in responding against any epidemics that broke out at the time. Traditional authorities were very central in making decisions in time of epidemic, for example, like cholera, like Kala-Azar, and also like smallpox, which broke out multiple times in different parts of the country. And the herbalists, most commonly women, all women, and executing the policies, for example, like isolating sick people, taking care of the breastfeeding mothers, and also telling people what to do, for example, like keeping themselves, keeping distant from another one, were all central at the time. In 2005, after the formation of the government of South Sudan, opened a health clinic outside the villages, which had never been having hospital in before. And so this showed the movement of people away from relying on herbs and on spiritual leaders and on traditional birth attendant toward the Western doctors or the clinical medicine. And as the movement goes, the conflict erupted after a few years in South Sudan. And in 2016, the economy slid down and the government stopped funding the hospital in the rural areas. This saw the emergency of private clinics in the rural areas that sell drugs expensively. The economic inflation raised the prices of drugs in the most part of the rural areas, and the communities, the local communities, which are poor and cannot afford to buy this drug, could not access hospital because there are either no doctors or there are no drugs in the hospital. This saw the return of the traditional healers, for example, like herbalists, to do their jobs once again. Many people whose babies are sick and they cannot afford drugs in the private clinic, going to the traditional healers to find the herbs. So when COVID-19 broke out, there was a significant growth of many people going to consult witch doctor or maybe herbalist as a means to treat their sick people. So when the COVID-19 broke out, the government started with the lockdown. And many people living in the rural areas depend on what they find in the market, going to work in the market, find something to eat and return to your house. So locking down somebody who has nothing in his or her house to eat is hard to be understood by the local people. So people try to go back to their own traditional knowledge of reorganizing market spaces and also household. Instead than to lock people down, you have to reorganize market to see that you are trading and you are observing some distance between you. And so this is what brings the traditional health system into the country's wider system, health system in South Sudan. And so as we speak, many households rely on traditional herbs and also are not listening or cooperating to the government policy to lock people down. Instead, they are looking toward a traditional mean of reorganizing market spaces and also their household to see that they are protecting themselves from virus and they are also doing their economic activities for a living. And so this is why we recommended that it's supposed to support these informal health workers to give them knowledge on how COVID can be transmitted so that they can talk to their own community in a language their communities can understand and incorporate it into their traditional way of protecting themselves from epidemics so that they can protect their own communities and go about doing their economic activities, which is the source of their livelihood in the country. So thank you.
Thank you, Joseph, for those thoughts. So I realize that we are over time, and I'm wondering if Alex and Michael are able to, just also contribute. Alex, and Michael, there's a specific question to you around, based on your work in Nigeria and Pakistan, what you think about improving, I guess, the sustainability of the tools beyond COVID. Is it infrastructural requirements, internet requirements, technical support that's needed, and also in data where data itself is a challenge, and this has to do with quality, availability, and actually the validity. Is there such support for countries, and what do you do in situations where that data is or the data systems are weak? And also just remember to, if you can, just contribute to the thoughts that were shared by Chris. Over to you.
Sure. So I think you picked up, and in the chat there were some good comments. I think they're all kind of linked up around some similar issues, which is the sustainability of the data systems we put in place now. And we've learned this lesson the hard way in past, particularly in the Ebola crisis, where in my slide deck, hard to capture, so many slides, so little time. But in the Ebola crisis, there was one deployment, which was mHero, which is a two-way health communications app, that all of those data tools were sunset, and there was no grant funding. And so we established a way to communicate. And at the end of the crisis, we severed that line of communication. And I think that's fundamentally what we don't want to do here. We want to make sure that we have sustainability. So we need to, I think the core of getting that right is approaching ministries of health and others where they are and helping build on top of the existing systems so that post COVID-19, these existing data health systems are better off than they were before. And we're relying on existing partnerships and we're relying on existing capacity, not trying to build new capacity and new tools, essentially just to address COVID-19. And I think that, and I think that gets at the bad data system investments that are also important. And then, finally, I think Chris picked up on a really important point, which was the variance aspect, which is, I think there is a moral imperative to vaccinate equitably globally. Failing that, in terms of getting vaccines globally available to everyone who needs that, we need to be very cognizant that transmission and risk and vulnerability need to be those targeted key aspects. And transmission is what helps us in terms of ensuring that additional variants don't end up popping up that we have to then contest with later on. And we can look to some of these data tools, these foundational data tools, to look at who's most at risk as it relates to transmission and ensure those populations are vaccinated earlier. So I think these are all really, I think, kind of deep points that it's hard to cover in a Q&A, but really good questions. Thanks, Stella.
Thank you, Michael. Very, very good points. I agree with you. Chris, would you like to just come in with some final comments before we say goodbye to everyone?
Just say thank you. Thank you, Stella, and the East Africa Research Hub for coordinating this discussion, which was really valuable. I think I was being deliberately provocative in my comments, because I think as we look over the coming few years, we need to, and we see the heterogeneity in how COVID is impacting. Actually, it highlights, I think, as we think through this, it highlights the importance of solutions which are appropriate for the specific local context, and that will differ within a country as well as between countries. And it highlights the importance of research which is being done within each specific context. So it was, and that's why it was so valuable to hear the presentations from today with evidence from a number of different contexts. Kenya, South Sudan, we heard Nigeria, in addition to others. So thank you so much for all of the presenters. This specific research, this regionally specific research is clearly incredibly valuable, and actually I think will become increasingly valuable as we look at this space. So thank you, Stella. Thank you everyone for joining. Really valuable.
Thank you, Chris, for leading those discussions. Thank you to all our presenters. It was really interesting. Thank you for taking the time to join us, everyone that joined. And yeah, we'll call it a wrap now. If you do have a few minutes to spare, we have a video to show you at the very end. Yeah, we'll continue the conversation.
Is evolving. 6 of the world's fastest growing economies in the last 10 years were in sub-Saharan Africa, and Africa as a continent has the most significant